inviting me here to Japan and giving me the opportunity to speak here in front of you. I have to admit I found the subject, when I was asked to talk about future perspectives of internal medicine and food animal, a bit challenging. But I thought this would be a good opportunity to get some thoughts I'm carrying around for years into a presentation. So before I start talking about future perspectives of farm animal and specifically bovine medicine, let me start by going back in time. Let's go back to the 1930s, 1940s. That is essentially the times of the tales of James Herriot. That was the classic country vet, the veterinarian who would essentially treat pretty much any domestic animal species that would happen to cross his way. And his core business would be individual animal veterinary care, which means to a large extent what we now call internal medicine. There would be a bit of surgery, there would be a bit of obstetrics, maybe gynecology, maybe orthopedics, but probably around 80% of the time would be dedicated to individual animal care. Now, as time passed and the production animal farming professionalized, it was essentially a development where producers ended up focusing more on productivity. They tried to increase their efficiency, their productivity, but they also realized that there are an incredible number of parameters, factors around the animal that do influence their economic success, which is productivity and the health of the animal. So they made some adjustments. They narrowed down the number of species they may have had in the farms. They may have even narrowed down production lines, going just for dairy or just for beef. And they tried to implement in their production cycle all these factors they now realized are important for the well-being of the animal. And this evidently also changed the expectations of the producer from its veterinarian, because the veterinarian was and still is the undisputed expert for all belongings that are related to animal health. But now evidently the spectrum became much broader because we assume that there are many more factors that influence animal health. It's not just providing internal medicine. Just as an example to show you this, I pulled a list that comes from a recent publication from the United States Department of Agriculture, 2014. This is an excerpt of a list of expectations of dairy producers in the US, what they do expect from their attending veterinarian, a service. And you can see that obviously the core business, which means diagnosis and treatment of individual animals, emergency treatment, is still there. That's still the core business where we expect expertise of the veterinarian. But apart from that, evidently there is a lot of areas where management skills are required, where assistance is required, where consultant is required, reproductive management, transition cow management, peri-parturient cow management, calf raising. So you see the spectrum of expertise expected from the veterinarian is broadened dramatically, which means essentially that the veterinarian nowadays is not spending 80% of his time on internal medicine, but much less, because he has to cover all these other areas. At the same time, we made a development. So essentially, let me just look at what happened with the development of the country vet. He needed to focus, he needed to adjust to these different expectations as well. So like the farmer focused on specific fields of production, the veterinarians tended to reduce the species, the variety of species they would be dealing with. So when we see, for instance, a census from 1940, from the AVMA, this is the American Veterinary Medical Association, you had approximately 60% of affiliated veterinarians that were somehow dealing with cattle. In 2010, this is only 13%. On the other hand, we had a new group of veterinarians that popped up in their list, which is veterinarians that predominantly or exclusively deal with cattle. So obviously, the veterinarians dealing with cattle, with food animal, focused on a specific species and sometimes even on a specific production line, which is their way of specializing. At the same time, internal medicine or medicine evolved as well. I called this here evolution from a low to a high maintenance discipline. Why do I say that? Because in the time of James Herriot, 1930, 1940, you really didn't need much expensive equipment as internist. You could excel in that discipline basically just by using your hands, your ears, your eyes, and your brain. I mean, we still need these tools, but the problem is that nowadays we are much more dependent on ancillary tools, ancillary disciplines as we advanced our diagnostic procedures. We have an increased number of pathologies that are accepted. This number increases pretty much by the day. Yeah? We have a much more in-depth understanding about etiologies, almost down to the molecular level, about pathophysiology. Yeah? And when we deal with clinical pathology, we need to have a basic understanding about how clinical pathology works. We need an understanding about pharmacology, about microbiology. So it's very evident that following up on internal medicine and trying to stay on top of the game does require specific advanced training. This cannot just be covered in the regular curriculum of a veterinary teaching hospital, as this was the case in the past. What this is saying that the production animal veterinarian at the time found itself at a crossroad. He had to decide where to go. Does he either serve the industry and then try to cover all these expertise areas that are expected from him, or should he at the same time really follow up on the individual animal medicine? And that is a trick because the day only has 24 hours and you have to cover. And the problem is what producers are telling them, you are required to deal with individual animals so that you cover most of the animals, let's say 80, 90%, maybe 95%, but the last 5%, they will be difficult to chase. And if you spend too much time on these last 5%, but at the same time you'll neglect areas that are relevant for the herd, this is not going to work. So they say there is a limitation because we put less focus on the individual animal and we try to put the focus on the herd. These are statements you commonly hear. As herd size increases, the focus of the vet should be on the big picture, not on the individual animal. Yeah? Or once the animal is sick, the game is lost. You should essentially try to prevent disease rather than putting too much energy into a curing animal. And this is a very healthy approach to say prevention is the primary part. This is the reality, everyday life from the production animal veterinarian. Now, I would like to give you the other perspective. This is the perspective from a clinician working at a teaching hospital. For me, there are two different circumstances under which you get your hands on a patient, it can be exactly the same patient, and ask to work it up. One is, I call this the 90% case. This is the majority of the cases that occur, an individual animal that is sick. Obviously, the moment you get presented this, the producer wants you to deal with this. But he will clearly ask you to respect the economic aspect, which means doesn't say he doesn't want any lab work, doesn't say he wants the cheapest treatment. What he wants is cost-effective treatment. You are allowed to do lab work provided it improves the diagnostic outcome and the treatment outcome. He wants effective and cost-efficient treatment. And ideally, you should limit the investment into this individual animal to the value of the animal. This is one case. This is what the producer is dealing with on a daily basis. But then you have the other case, and I call this the sentinel case. Now the same patient comes in as an animal representing a problem on the herd. In this case, the value of the individual animal becomes almost negligible because now the result, the value of this animal is what you get from the herd, what you get from this animal to reflect on the herd. In this case, you are allowed, no, you must exactly run every diagnostic test you need to consolidate to diagnose, to make sure that the diagnosis is correct because this will have a huge impact on the herd. So you see two different approaches, and this is clearly the rare part, the more uncommon part. And what I can tell you from experience, usually the producer does not expect from his attending veterinarian that he's able to deal with these 5% cases. But what they do expect is that there is somebody somewhere who has the expertise to deal with this. And this somebody, as far as when it comes to internal medicine, is probably an internist, and the somewhere is probably in a teaching hospital somewhere. So clearly, even if the industry says, well, we limit this to the production animal level, we don't put too much energy on the individual animal, the moment the need is there, they do expect that the expertise is available somewhere, practically at their fingertips. I wanted to look into this issue about herd size and how this changes the expectations from the veterinarian. And this is, again, this list from the USDA NAMs. I'm going to zoom in here so you can see this. I wanted to focus on the few aspects related to individual animal medicine. These are essentially the emergency service, the standard diagnostics and therapy, and I put as a classic example the treatment of abomasal displacement. And you see here this is stratified by small, medium, and large, and this is questionnaire data. So essentially, this is the question to the veterinarian, to the farmer: where do you expect expertise, assistance from your attending veterinarian? And what you can see, well, there is a tendency to decline here. Number of producers that expect help with emergency, with diagnosis, and then obviously with abomasal displacement. So there is a trend to decrease, but the numbers are still high. So this is clearly telling you the expertise for individual animal care is still undisputed. It is with the veterinarian. And apparently, it's still expected that the veterinarian deals with it. It doesn't mean that the veterinarian has to do it all itself. Maybe he's delegating that. You can debate if you want that or not, but the expertise, the teaching of the lay personnel who is doing that still will come from the veterinarian. So what this is saying, even in a large herd, probably the veterinarian is dealing with less clinical cases, but the expectation is there, should it be requested, that the veterinarian can deal with this. So the expertise should remain. The other thing I wanted to look at is the association between herd and disease size, because you would expect, evidently, if you increase the herd size, you get the whole system more efficient, you can systematically approach herd health issues, you can do prophylactic programs, so you would expect that disease incidence will decrease. And this is something you indeed can confirm in some areas. So this is, again, from the NAM study. I pulled up a couple of common diseases. Here you see small, medium, and low herds, and large herds. Yeah. And what you see, for instance, milk fever, ketosis, you can see that you nicely can drop the incidence of disease with increasing herd size. This is probably because it's very easy if you have large groups, feeding groups, to manage ketosis and milk fever. It's probably easy to deal with DAs. You have other areas like, for instance, clinical mastitis or respiratory tract disease, where this doesn't do much. So the incidence doesn't change by our herd size. You have other areas where apparently it goes the other way around. So you get more, like for lameness and metritis, although for metritis, I think this is an artifact. Probably these large herds are more systematic in looking for disease, and then they probably will find a higher incidence than smaller herds where this is not systematically worked up. But what I'm saying is, it is a good thing that production medicine essentially is successful in decreasing in disease incidence in herds that are larger, where you can systematize the whole procedure. But it also says that disease will not go away entirely. And what we have to admit is that we have areas where we're still dealing with very basic issues. Let me take as an example here, failure of transfer of passive immunity. I mean, this is something we're preaching and teaching for decades now. And these numbers come from all over the world. I don't want to discuss details here, but it's very clear that we are not yet where we should be. And if we push that further, the consequence when we look at calf mortality rates, I mean, this is, again, example, just because I had it in my hand here, industrialized world. Dairy in the US, stratified again by herd size, small, medium, large, pre-weaned and weaned calves. I mean, if you take that together, our calf mortality rates are still somewhere between 8 and 12%. And if we look further, causes for mortality, pre-weaned calves, almost 60% diarrhea. Weaned calves, almost 60% respiratory tract disease. I mean, we know this. But what this is essentially saying, that every year, still, diarrhea is wiping off 4 to 5% of our calf population. As long as we're dealing with these numbers, treatment will remain relevant. Now, you will say with all the right, well, I don't need a specialized veterinarian. Every production animal should be able to deal with pneumonia, with calf diarrhea. That is correct. But what I can tell you is, for instance, if we take the example of diarrhea, we made a lot of progress over the last 20 years to understand the pathophysiology of diarrhea. It's not that we now know better why calves deteriorate and eventually die. No, this has an impact. It has an impact, for instance, we're discussing now about what is the best buffer, what is the best combination of buffers in electrolyte solution. We're discussing, should we keep sticking to our hypertonic electrolyte solution, or would it be better to use isotonic or even hypotonic? So there are things moving. And the moment this development we're currently doing ends up in practice and results in decreased mortality rates and shortened morbidity rates, that's the time this work pays off. The same thing, respiratory tract. I mean, you will hear today there will be some lectures about novel tools to assess diagnostic early disease, respiratory disease, because we have papers coming out for years now that tell us that our diagnostic precision, our sensitivity to diagnose early stage respiratory disease isn't good enough. But there is something that is happening right now, and something that hopefully eventually will end up in practice and then will result in an improvement of disease outcome and thereby have a payback. So let me come back to my picture of the veterinarian on the crossroad. I mean, this is something because I just wanted to focus a bit on the continuing education part, where you say either you follow up on internal medicine or you follow up on production medicine, because you won't be able to ride on both horses if you want to be successful. So if you go for the production medicine part, which is essentially what you do when you want to stay in practice, there are, on a national level, there are a couple of programs that have been implemented. Probably the best established, I know, maybe there are in other countries some well-established program, is the one from the ABVP, the American Board of Veterinary Practitioner, that offers specialty trainings in specific subfields like beef, like dairy, like food animal. In Europe, we have the European College of Bovine Health Management that is in the development. It's not yet well established in practice, but it's going into that direction. This is a training program that is customized to meet the needs from the industry. And the needs from the industry is to cover a whole range of things, among them internal medicine, but up to a certain level. We don't need the top-notch treatment, because the last 5% I mentioned before will just be so rare that they will not pay off. You better invest the time for the last 5% in something that is more relevant, more efficient for production medicine. The other thing is the training for veterinary internal medicine. And this is a bit different because historically this started as a really specialty training. So we said we deal with internal medicine. Probably the first one was the American College of Veterinary Internal Medicine, and they said, well, we have internal medicine. They put every species together, it's more or less the same. As this developed, they realized, well, this is not going to work because the training will be for a lifetime. So they split in the late 90s, early 2000s, they split this into large animal and internal medicine. In Europe, they learned from this, and they went right away when they had the European College of Veterinary Internal Medicine, they stick right to companion animal. Why did they do that? Because most of the people that are in there are essentially in practice. So this is, again, practice-driven. And they know if you are a board-certified companion animal veterinarian in internal medicine, chances are small that you will also be dealing at an advanced level with equine or with food animals. So just let's focus on companion animal. And equine did the same thing. They came up with the European College of Veterinary Internal Medicine. Again, something because they know the equine internal medicine specialist is very unlikely to intensively deal with cattle. So why should he bother in his training with food animal medicine, internal medicine, because this is quite complex and this will consume quite some time. So as far as training for food animal internal medicine is concerned, probably the best you can get is the ACVIM farm animal training, large animal training, which unfortunately, I should not say this, but comprises a good part of equine medicine and comprises the farm animal medicine, but on the other hand, leaves out a lot of things that are relevant for practice, like the economic aspect, like surgery, like chirurgenology, which means this will never pay off in practice. This is essentially opening doors for academic careers. And having said academic careers, I'm always saying, what's the perspective? If you are board certified SCVIM diplomat and you want to go to practice, I mean, the number of positions is limited. So you could ask yourself, is it justified to maintain a specific program just for food animal medicine, food animal internal medicine, if only academia is the target where you can successfully work? I'm I doubt, but I'm open for discussion. But you could push this a bit further even. You could say, well, why don't we skip these 5% altogether? Why don't we leave and teach production medicine at the production medicine level? And we say, we don't take this any further because the last 5% will never ever pay off. So we just do this to the production and medicine level, and once we're beyond that, well, so be it. We can deal with that, animal goes to slaughter. And that for me was the point where I said, well, maybe we need to come back and just think about our reason of being. What is the role of bovine internal medicine? What do I think is the role? Because this is not a consensus statement. This is my personal opinion. So I wanted to come up with what I thought would be, for me, the 5 most important points why we should stick to internal medicine. And I have to admit I struggled a bit with this list. And you may not agree with the order, you may not agree with the things that are in. For instance, I was struggling with, should the One Health initiative be in there? You see, it's not in there, but it's not in there because I think it's not important. It's not in there because I thought this would drift me too far away from my objective today. So essentially here in my top 5, the first one is quality assurance in clinical education. Advancement of diagnostics and therapy in bovine medicine. I'm going to go through these points in detail in a minute, yeah? So don't be afraid here. Availability for consultant referral. Contribution to surveillance of population health. This is an important point. And then maintenance and advancement of expertise. Again, this is not an exclusive list. This is the things I thought that would be, for me, a really strong argument why we should try to foster the development of bovine internal medicine. The first one is quality assurance in clinical education. And this essentially are 3 points. This is clinical education at a undergraduate level. This is basically veterinary student education. Going to talk about this in a minute with a bit more detail. We have the graduate education, which means you're providing further education for people that want to become specialists, for people that need advanced training for their future career, that can be a scientist, that can be specialist in other areas. Yeah? And then we have the continuing education for veterinarians and producers. I mean, the veterinarians, the practitioners, the food animal practitioners, they are compelled to continuing education for their entire professional career. They need to follow continuing education, but as far as internal medicine, it is our responsibility to compile the information they need. If there is advancement, if there is a new disease, if there is a new diagnostic procedure, it is our obligation to put this information available so that they can stay at top of the game, that they can do their work successfully. This is what we need to do. No? As far as undergraduate and graduate teaching is concerned, I mean, there are 2 parts. There's the theoretical knowledge and there is the practical skills and hands-on training. The theoretical knowledge, evidently you can say, well, there are books, so everybody can read, so why do you need somebody to lecture? That might be true, but the thing is, medicine develops relatively fast and the turnaround of textbooks is slow. Usually it takes 8 to 10 years before you get a new edition. Sometimes it takes 20 years. Now you can say, well, students bypass this by just recurring to online resources. That is true as well, and this presents another challenge because students have a wealth of information at their fingertips just because they're using Google as their standard textbook. The problem is the students are not very well trained in assessing quality. So they have a lot of information. All of a sudden, in a teaching room, there is something that pops up, and if you don't have anybody in the room who is able to deal with this, this may present a challenge. So it's very helpful. It's very clear that not one person cannot essentially filter all the information and say what's good, what's bad. But evidently, it will help if you have somebody in the room that has this in his expertise field and is able to start a discussion about quality of resources in teaching. The other thing is the practical skills. I mean, here again, we will agree you do not need a board-certified internal medicine specialist to teach how to do a physical exam on an animal. To the contrary, this is an excellent training for a first or second year resident, provided you have somebody who supervises that and somebody who teaches the teachers. So you have to supervise what they're doing. And the other thing is, it's one thing to do a physical exam, and it's a whole other thing to put the findings of the physical exam together to a meaningful differential diagnosis list. And this is something where students struggle, where first-year residents struggle, and you can even have board-certified internal medicine specialists working in equine or in companion animal that would struggle here because in some areas, food animal internal medicine can be quite specific. So here again, it helps tremendously if you have somebody in charge of this education that has this area in his comfort zone. The next thing is diagnostics and therapy, advancement of that. I mean, here, probably, I mentioned that already. Excuse me. The classical example is the development of ultrasonography. I mean, when I did my residency in Illinois in 2000, I mean, we pulled out the ultrasound machine maybe once, twice a week. Today, ultrasonography in a referral clinic is an undisputed, well-established, advanced tool that is used on a routine basis and that has an improved effect on the quality of diagnostics. And this is a good thing. In the meantime, in teaching hospital, there is virtually no tissue that has been scanned, and there are plenty of papers that have been published about scanning and diagnosing different tissues. And in the meantime, as these machines become more and more available, you see these practices coming up in the field. Veterinarians now start using ultrasonography to facilitate their diagnosis of hardware disease. They start using this to assess the extent of an umbilical infection in calves. They start maybe using this to determine if an animal with an acute abdomen is a surgical case or not. Just a few examples. And this pays off the moment this load of work that has been done 10, 15 years ago ends up in practice, evidently because the equipment that was prohibitively expensive 10, 15 years ago now becomes accessible for practice. The other thing is advancement of treatment. And this is another thing. I mean, I hate to say this, but I mean, let's face it. Medicine, bovine medicine is packed with dogma. I mean, there are plenty of things we're doing just because we're doing it. I'm giving you an example here. I mean, fresh cow therapy. I mean, there are plenty of farms where a cow calves and then somebody comes with a cart and then they get infused with all sorts of solutions. They get calcium, they get glucose, maybe they get phosphorus, maybe they get hypertonic saline, you name it. I mean, I'm not saying this is a bad thing to do. I'm just saying if you look at the evidence, there is not that much evidence. The same thing for drenching. I mean, for some salts, we have evidence that this is a good thing, but there are a plethora of salt combinations on the market, and we're drenching this. And again, I'm not saying this is a bad thing, but what I'm saying is the moment we are having a standard treatment protocol, and we're using this on a lot of animals at a time where we're becoming stricter and stricter about the quality of products that end up in the food chain, I think it would be a good time to increase a bit the science basis of what we're doing. Just as a thought, and there would be plenty of work to do here. The next thing is the availability for consultant referral, and this is evident, right? Because I said we stick to the 5% cases to the left. We stick to these 5% of cases to the left, but we should not leave the industry. We should not leave the attending veterinarian alone with this. They should know, hey, in case I reached my limit, because when I'm talking about internal medicine, what I actually mean is internal medicine at the top level of the production medicine veterinarian and above that. So clearly, in some instances, the production animal veterinarian will reach this limit. In most cases, they are so good that they can deal at least with 95% of the cases. But in cases they reach the limit, they should know we have backup. There is somebody that can help me. This can be just a case discussion. This can be consulting, advising about what further diagnostic tests to do or to interpret these diagnostic tests. We also need to be available for authorities, for institutions. So there's a problem coming up associated to production animals, and we are the resource for these authorities to help them come up with an informed public opinion. So this is our responsibility to say, hey, this is how the things is, and then we can provide you with some background information on this. When I come now to the population health surveillance thing, this is what I call the contribution to sentinel surveillance. Population health surveillance is not an internal medicine duty. This is everybody's duty. We have our share in this, and you'll see where I see the share in this, but this is essentially advice, information for practitioners, producers, authorities. Let's say there is a new disease coming on. It's our responsibility to tell them, hey, this is coming on, these are the things you need to be looking for, these might be your diagnostic option. So we contribute to this. We may be able to take in patients to work up to do further diagnostics. So we need the facilities for that, we need the isolation units, yeah? And we may need to be the link between disciplines. So we get this in and we make the connection to ancillary disciplines that help essentially to solve this problem. And I'm talking about a variety of things. This could be emerging diseases like 20 years ago, BSE, or more recently Schmallenberg. Or we could have transboundary diseases, diseases that are moving on as the climate changes. That could be, in Europe this was blue tongue, or right now there is the lumpy skin disease in front of the door. We have the risk of re-emerging diseases. That could be foot and mouth disease, or that could be bovine TB that is coming up every now and then. Or we may have diseases that are not a problem for the animal, but may be a problem for the consumer, like for instance EHEC. And then we have some congenital and novel diseases. Essentially here we have the bovine neonatal pancytopenia, a really exciting story we had kept us busy 4 or 5 years ago. In the meantime, nobody talks about it anymore because it's resolved. Or there is this cholesterol deficiency haplotype I would like to briefly go into, not because I think it's so important, because I can provide some first-hand experience on that, and I wanted to share this with you. I wrote here unraveling novel pathologies. Actually, when I saw that last night, I went through the slide, I said, well, I should have called this falling over novel pathologies, because this is what it is. We fell over a novel pathology, something we could have fallen over 10 years earlier. What is this? This is about a veterinarian who is working in a clinic and every now and then sees calves that are not growing well, but are eating aggressively, and you find cholesterol values that are at or below the detection limit. I mean, we don't run very much cholesterol, but it's very unusual to see that low values. But then the calf dies, and you see rare lab results every now and then, and you can't make a sense of everything, so you just forget about this until half a year later this comes up again. Well, it dies again, until the moment you get a call from a National Breeding Association and they tell you, hey, we have a situation. We have a high genetic line receiving every care they can get. Veterinarians are chasing this down, and still we have animals that do not survive the first year. You've got to figure this out. Okay. So you get a couple of addresses, you get a couple of ear tags, and then you go on the farm, and essentially, well, you look at the calves, and you just see a couple of poor growing calves like you see every day, and then, well, you recur to lab work because you don't know what else to do. And in the lab work, you will find pretty much every abnormality you can think of. But one thing they have in common is they all have a cholesterol at or below the detection limit. So you wonder, well, what's going on? So you start reading up and you realize you basically know nothing about this cholesterol metabolism. I mean, is this a digestive tract problem? Is this a hormone problem? Is this a liver problem? Is this a transport problem? So you start calling up people, and the group gets bigger and bigger. And by the time you put up a paper, because you think now it's time to basically communicate this because calves are dying, you end up with almost 20 authors covering 25 disciplines, and you still have plenty of loose ends there. But every single author essentially here had his contribution here. You remember my subtitle here that was Finding a New Balance Between Discipline? This is what it is. This is not about internal medicine just using the help of a bit of lab work. This is about putting the hubris of the clinician away and putting the expertise of everybody to the best use. And the best use here is essentially a joint venture to kill disease. And once this was described, it took no time essentially to eliminate this disease. It's very rare now. What's a bit disturbing though is if you look at the haplotype frequency here, this thing was there for 15 years, for over 15 years, and lately it was killing tens of thousands of calves every year. And things like that will keep popping up as long as we're breeding animals, for sure. So we need to be there. And I mentioned before, well, what's the role of the internal medicine clinician? At the time, 30, 40 years ago, you had diagnostic labs that were providing assistance to the production animal veterinarian. It was assumed that there was no gap between them. The production animal veterinarian or the farm animal veterinarian was expected to squeeze all the possible juice he could get out of the living animal. And then the lab would follow up. Either the veterinarian sends up specimens that can be analyzed, or he sends up a dead body or carcass that would be worked up. And then you get the big picture. Nowadays, we have the problem that individual animal medicine, the diagnostic part is so developed that the veterinarian in practice cannot completely cover this. This is normal. Nobody can expect that for that. But that is essentially the area where internal medicine would kick in, where you say, okay, now we take this animal, we work this up with advanced diagnostic tool. We'll never, ever pay off for the value of the individual animal. But the objective is to improve herd health. So this just as an example, and certainly this is not an exception, and certainly this is not the most exciting story. I'm just telling this because I happen to go through this. Now I'm coming to the last point, I guess, which is the maintenance of advancement and expertise level. And this is essentially assuring that when I have novel information, I need to share this nationally, internationally. I have to make sure that this information is conveyed, that I'm not sitting on this. This could be a meeting like this here, but essentially the scientific exchange, not only between veterinarians, but also between disciplines, between human medicine and veterinary medicine. This is what we cover in the One Health initiative. The research activity. I mean, we have a lot of expertise, everybody in a different field in internal medicine, and evidently everybody's working on his research field. This would be probably fundamental research you need grants for. This is an important thing. And then you also would have the research you're doing on request. This is essentially research you can do for the industry because the dairy industry is dealing with a certain problem, you're working that up, or the pharmaceutical industry, because we have the expertise, we have the equipment, and we have the facility to do that. So that is a contribution we have to do, and I do not think this can be covered by anybody else. And then we have the knowledge transfer that needs to go in all directions. Knowledge transfer from the clinic, the ivory tower, to practice, that needs to go from clinician to clinician, that needs to go from discipline to discipline, so that needs to go to the next generation. So this is, we need to make sure that the scientific development not only thrives, but is at least maintained. So, with this, I think at least I hope I created some awareness why I believe it is important to support internal medicine and to foster this so that the development in health of the individual animal, health of the population is maintained. This takes me to the inconvenient part of my talk, which is essentially what do we need to do to foster the development of individual animal medicine. If you want to sit here, there's plenty of room in the front, so don't worry just to come up front. You don't need to stand here. What I'm coming up here, and I will tell you, I mean, you will see in a minute where this is going to. I mean, when we talk about teaching and education, I mean, it's clear we need to be close to the students. I mean, teaching and education for veterinarians, we can travel, we can do meetings, but as far as students are concerned, we need to be involved somehow in the teaching institutions. And if we want to do teaching, we probably need clinical cases, which means we not just need to be involved in the teaching institutions, we need to have a teaching hospital where we can at least board animals that we have material to do some hands-on treatment. And if we want to do advancement in the field, which means we want to do research either for the industry or for ourselves, we need facilities. And we not just need a room, we need stalls, we need equipment. We need equipment, we need personnel, and we need the financial support. So you see already where I'm getting to here. The other thing is population health and surveillance. Here, we need proximity to the industry. We cannot do that if we are 500 miles away, because with the distance, essentially, we become less accessible, where we need to be able to go out there or even be able to take animals in for a referral. We may at the same time need to have ancillary tests available, so we need ancillary discipline close to us. It's not a good idea to just plant a teaching hospital in the middle of nowhere where you don't have pathology and all the other tests. And you need to maintain availability and expertise, which means integration and connection of the expertise with all the other fields, with clinical pathology and so on. So you see what I'm getting at. I mean, the question is, at the moment we're dealing that in the form of a teaching hospital, and I do believe that the teaching hospital is not really a good solution for this, but I don't have any better one. If we can come up with something better, then just let's talk about this. Because at the moment, we're dealing with veterinary teaching hospitals. Many of them in the world are on life support. Yeah? We're trying to maintain them because we know that it's a problem if we lose them, but on a long term, we may not be able to keep them up. I call this a troubled child. Yeah? Because what we need is not just a building, we need adequate caseload. Yeah? Caseload in quality and quantity for teaching and for research. And we need the equipment. And the equipment, this is expensive. We need to be able to do some ambulatory work. Not everything needs to be done in-house. Yeah? We need the equipment, because if you want to attract clients, if you want to attract researchers, you need to be equipped so that you can say, hey, we can deal with this. Yeah? At the same time, the moment you're hauling in and out animals, you have a biosecurity issue, a big issue you need to address, otherwise this will explode. And this needs to be addressed as well. Yeah? Safety requirements, because you're dealing with lay people. When you're dealing with students, you cannot just put up a barn. You have to have special safety requirements. And again, the proximity to ancillary tests. Yeah? And this takes us to our problem. How do we get the hands on our caseload? Because in many cases, where is the VTH, the teaching hospital, located? It's located in a university, and the university is, in most cases, in an urban area, and in the urban area, we're losing the density of cattle, which means the distance increases, and distance increases means longer holding time, and this essentially causes reluctance with the producer to send in animals. Yeah? At the same time, the producer knows, well, my veterinarian can deal with 95% of the cases. Why should I send something in? He will send in the referral cases, but if we only have the referral case, we don't really have a good basis to maintain the teaching hospital. And we remain with the biosecurity concern. So clearly, if we want to go for this, this means we need to subsidize. We need to subsidize, we need to cover up the cost, the extra cost that the producer would have if he brings in animals. Yeah? Now, I'm almost at the end of my presentation because I see your time's running up. I pulled up a mission statement from an AVMA paper from 2003. So they brought up the points what a farm animal teaching hospital or teaching hospital in general should be for. Yeah? To provide clinical environment for veterinary education, to provide advanced clinical experience at postgraduate level, yeah? To provide faculty and students with clinical cases used for research and advanced disciplines, yeah? And to provide service for animal owners, referring vets. And here the last point, to generate income to cover costs. You see I left a couple of points out here because I added what I feel it's important, the surveillance thing, which is not probably an issue for companion animal, but clearly is one for food animal. And the other point I added, well, we need to generate significant income, but we need to think about the currency. The income for food animals should not be covered at the reception desk of the clinic. The income comes essentially from decreased disease incidences, from improved animal health, maybe a few years later, based on the work we're achieving at a teaching hospital. I'm saying this because I think the moment, if we can commit ourselves that we need a veterinary teaching hospital or we need to maintain internal medicine, we need to talk about money. And talking about money means sharing costs. And we are doing this already. I mean, here, this is not by order of importance. This is by order. I covered this where I said, well, who needs to cover? Because everybody who takes advantage, it should take its share. I mean, students evidently have to take its share if they are paying for the education. In states where the state takes care of that, the state will do this. This is already happening. Yeah? Public and state, in many cases, this is the case. If you don't have a university, they will essentially cover some of the costs. But the state should also cover not just to maintain teaching education, but he should also cover the responsibility for herd health management, because this is essentially an extension of the diagnostic lab. The industry, and here I mean the farm animal industry, should cover as well, and this is not happening currently. I believe this should happen because they ultimately are taking advantage as well. This should not be the patient that comes in that is paying. This is not going to work. This should be essentially the industry that is covering, that is pitching in, like they're doing that now for a couple of notifiable disease, where they say, hey, they have a fund here, and we have to pay because there will be a payback the moment we need this information. The patient owner, he should pay to defray, or basically to cover costs, an advantage he's taking, but he should not be covering for all the expenses that incurred, because many of them are essentially used to advance our expertise and advance our routine. So, sermon over. Thanks for listening.
Dr. Bolzer.